Hello. Today we will cover the objectives for week 1. This presentation is in two parts, Part A and Part B. This is Part A. Chapter 1, Perspectives of Pediatric Nursing. The major goal for the pediatric nurse is to improve the quality of health care for children and their families. Healthy People 2030 provides indicators for improved health for children. Bright Futures is a national health promotion initiative with a goal to improve the health of our nation's children. Major themes of the Bright Futures guideline are promoting family support, child development, mental health, and healthy nutrition that leads to healthy weight, physical activity, oral health, healthy sexual development and sexuality, safety and injury prevention, and the importance of community relationships and resources. Leading health indicators. These are issues and priorities for the American children. Poverty, lack of health insurance, environmental health, nutrition, firearm deaths and injuries, mental health, racial and ethnic disparities, immigration. Childhood health problems include obesity and type 2 diabetes. These can be caused by children who are overweight and obese. And being overweight is defined by having a BMI of 85% or more and equal to 85%. And obesity is a BMI greater than or equal to 95%. 20% of kids are overweight and 18.5% are obese. There are many factors that contribute to this statistic. Childhood injuries. Developmental stage and environment are important determinants in the prevalence of injuries at a given age and thus help direct preventative measures. Box 1 talks about childhood injuries risk factors. These include the gender, mainly males, and this is a result of behavioral characteristics, especially aggression, temperament, children typically with a difficult temperament profile, stress, alcohol and drug use, history of a previous injury. This actually increases the likelihood of another injury. Developmental characteristics, a mismatch between the child's development and the skill required for a particular activity. The natural curiosity to explore the environment, the desire to assert self and challenge the rules. In older children, a desire for peer approval and acceptance. Cognitive characteristics, which are age-specific. The infant, they're in the sensory motor cognitive phase, and they want to explore the environment through taste and touch. The young child, here they are developing object permanence, and they are actively searching for attractive objects. They lack awareness of consequential dangers, and they are unable to comprehend danger to themselves or others. The school-age child, they might attempt dangerous acts without detailed planning regarding consequences. They're unable to fully comprehend causal relationships. The adolescent, they're preoccupied with abstract thinking and they might lose sight of reality. This may lead them to feeling like they are not vulnerable. Anatomic characteristics, especially in young children, include a large head. This predisposes them to cranial injury. A large spleen and liver with wide costal arch. This can actually predispose them to trauma in those areas. A small and light body can be easily thrown, especially inside a moving vehicle. Other factors include poverty, family stress, substandard alternative childcare, young maternal age, low maternal education, and multiple siblings. Mortality. This basically is the causes of death in rate per 100,000 population in each age group. The major cause of death in children over 1 year of age is unintentional injuries. These include motor vehicle accidents, drowning, burns, firearms, and poisoning. Overall, the majority being motor vehicle injuries. Drowning is number 2 for males up to 4 years of age. 95% of medication-related ED visits in children younger than 5 years are due to ingesting medication while unsupervised. Intentional poisoning associated with drug and alcohol abuse and suicide attempt is the second leading cause of death in adolescent females and the third leading cause of death in adolescent males. Violence is everywhere. The presence of a gun in a household increases the risk of suicide by 5-fold and homicide by 3-fold. Adolescent vaping is an epidemic. The use of e-cigarettes has become a national epidemic. The rise in vaping, that is using e-cigarettes, reported in 2018, had increased by 78% in the high school student and by 48% in the middle school student, which is even more concerning. Mental health. 1 out of 5 children have mental health problems, and 80% of chronic mental disorders begin in childhood. Infant mortality. This is the number of deaths during the first year of life per 1,000 live births. Causes are congenital anomalies, low birth weight, problems due to prematurity, newborns affected by maternal complications of pregnancy, sudden infant death syndrome, and accidents, which are your unintentional injuries. Neonatal mortality is for an infant less than 28 days or equal to 28 days of life. Birth weight is considered the major determinant of neonatal death in technologically developed countries. Childhood mortality. Overall, number 1 is unintentional injuries, 2 is suicide, and 3 is homicide. This can slightly vary within specific age groups. Morbidity. This is an injury or illness with symptoms severe enough to limit or require medical attention. Respiratory illnesses account for approximately 50% of all acute conditions. 11% are caused by infections and parasitic disease, and 15% are caused by injuries. These statistics are used for many reasons. By knowing this information, you can teach families injury prevention measures. The art of pediatric nursing. Nursing of infants, children, and adolescents involves the protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, and populations. Family-centered care is an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients, and families seeking healthcare in all settings. Key elements of family-centered care include incorporating into policy and practice the recognition that the family is a constant in the child's life, whereas the service systems and support personnel within those systems fluctuate. Facilitating family professional collaboration at all levels of hospital, home, and community care include care of the individual child, program development, implementation, and evaluation, and policy formation. Exchanging complete and unbiased information between family members and professionals in a supportive manner at all times. Incorporating into policy and practice the recognition and honoring of cultural diversity, strengths, and individuality within and across all families, including ethnic, racial, spiritual, social, economic, educational, and geographic diversity. Recognizing and respecting different methods of coping and implementing comprehensive policies and programs that provide developmental, educational, emotional, environmental, and financial support to meet the diverse needs of families. Encouraging and facilitating family-to-family support and networking. Ensuring that home, hospital, and community service and support systems for children needing specialized health and developmental care and their families are flexible, accessible, and comprehensive in responding to diverse family identified needs. Appreciating families as families and children as children, recognizing that they possess a wide range of strengths and concerns, emotions, and aspirations beyond their need for specialized health and developmental services and support. 2 concepts we want to remember with family-centered care is enabling and empowerment. Professionals enable families by creating opportunities and means for all family members to display their current abilities and competencies and to acquire new ones to meet the needs of the child and family. Empowerment describes the interaction of professionals with families in such a way that families maintain or acquire a sense of control over their family lives and acknowledge positive changes that result from helping behaviors that foster their own strengths, abilities, and actions. Culturally sensitive care is necessary because when family cultural values are incorporated into the care plan, the family is more likely to accept and comply with the needed care, especially upon discharge. Often health behavior patterns are learned from parents and past generations to future generations. Atraumatic care provides care through the use of interventions that minimize the psychological and physical distress experienced by children and families in the healthcare system. The overriding goal in providing atraumatic care is as follows. First, do no harm. 3 principles provide the framework for achieving this goal. Prevent or minimize the child's separation from the family. Promote a sense of control, and prevent or minimize bodily injury and pain. Children do have rights, and the United Nations Declaration of the Rights of the Child include all children need to be free from discrimination, to develop physically and mentally in freedom and dignity, to have a name and nationality, to have adequate nutrition, housing, recreation, and medical services, to receive special treatment if handicapped, to receive love, understanding, and material security, to receive and understand, to receive an education and develop his or her abilities, to be the first to receive protection in a disaster, to be protected from neglect, cruelty, and exploitation, and to be brought up in a spirit of friendship among others. Chapter 2, Influences on Child Health Promotion. The family structure. The family has been defined in a number of different ways and are made up of individuals, each with a socially recognized status and position, who interact with one another in a socially sanctioned way. It is a group of 2 or more people related by birth, marriage, or adoption and residing together. The U.S. Census Bureau uses 4 definitions for family. 1, traditional nuclear family, which is a married couple and their own biological child. 2, nuclear family. 2 parents may or may not be married with children, may or may not be biological. That is, they could have stepchildren, adoptive children, half siblings, foster children. A blended or reconstituted family. This is where you have 1 step parent, step siblings, or half siblings. The extended family, this is where you have a parent, a child, and then 1 or more other people other than the parents or siblings. An example of this could be like a grandparent living in the household as well. Other families can be single parent households. This is where 1 parent is raising the child. About 35% of children live in single parent households. Binuclear or joint custody households. This is where the parents continue the parenting role while terminating the spousal unit. Polygamist, this isn't legal, but typically you're going to see more than 1 woman shares the husband with other women and children. Communal, also pretty uncommon. Here the focus is the goals of the community. They often share goods and there's a reliance on each other. LGBTQ, this is a legal or a common tie between 2 people who are not cisgendered, male and female, who have children. It's important to be open and non-judgmental when caring for these families. So let's talk about some qualities of strong families. The qualities that they tend to have are, there's a commitment towards family well-being, an appreciation for the family to do well and to do better. They spend time with each other. They have a sense of purpose. There's a sense of congruence regarding the value and importance of assigning time and energy to meet needs. They communicate in a positive manner. They have family rules, values, and beliefs. They use a variety of coping strategies and engage in problem-solving activities. They're able to see the positive aspects in life, and they're also able to see the opportunity for growth during times of crisis. They're flexible and adaptable, and they have a balance between using internal and external family resources for coping and adapting to life events and planning the future. Next, we'll talk about parenting styles. The three that we're going to be talking about are: one is the authoritarian or dictatorial style. This requires unquestioned rule following. You will do it because I said so. The permissive or laissez-faire parenting style is where there's little or no control over the children. There's very inconsistent discipline. Authoritative or democratic style combine both of the previous styles. Control is firm and consistent, but it's tempered with encouragement, understanding, and security. Limit setting and discipline. Discipline means to teach and refers to a set of rules governing conduct and actions taken to enforce the rules. Limit setting refers to the establishment of rules or guidelines regarding behavior. Limit setting serves several functions. It allows children to test their limit of control, achieve in areas appropriate for mastery at their level, channel undesirable feelings into constructive activity, protect themselves from danger, and learn socially acceptable behavior. What can we do to minimize misbehavior? A big one is set realistic goals for acceptable behavior and expected achievements. Structure opportunities for small successes to lessen feelings of inadequacy. Praise children for desirable behavior with attention and verbal approval. Structure the environment to prevent unnecessary difficulties, like placing fragile objects out of reach. Set clear and reasonable rules. Expect the same behavior regardless of the circumstance, and if exceptions are being made, let them know it's only for one time. Teach desirable behavior through modeling, such as using a quiet, calm voice instead of yelling. Review expected behavior before special or unusual events, such as visiting a relative or having dinner in a restaurant. Phrase requests for appropriate behavior using positive words, such as put the book down versus don't touch the book. Call attention to unacceptable behavior as soon as it begins. You want to use distraction to change the behavior or offer an alternative to annoying actions, such as giving them a quiet toy instead of a very noisy toy. You also want to give them friendly reminders, such as when the TV program is over, it is time for dinner. Or I'll give you to the count of 3 and then we need to do whatever it is you need to do. Be attentive to situations that increase the likelihood of misbehaving, such as overexcitement or fatigue. Offer sympathetic explanations for not granting a request. Keep any promises made. Avoid outright conflicts. You want to temper discussions with statements like, let's talk about it and see what we can decide together. Or you might have to say, I need to think about it first. Provide the child with opportunities for power and control. Implementing discipline. Consistency. It is very important that for each disciplinary action, discipline is agreed upon for each infraction. So you want to be consistent. You want to do the same thing every single time. Timing. You want to initiate discipline as soon as a child misbehaves. If delays are necessary because you don't want to embarrass them, you can verbally disapprove of the behavior at the time and state that disciplinary action will be implemented possibly at a later time. Commitment. You need to follow through with the details of the discipline, such as timing of minutes, avoiding distractions that might interfere with the plan, such as telephone calls. Unity. You got to make sure that all caregivers agree on the plan of discipline and are familiar with the details to prevent any confusion and alliances between the child and one or the other parent. Flexibility. You want to choose disciplinary strategies that are appropriate to the child's age, temperament, and the severity of the misbehavior. Planning. Plan discipline strategies in advance and prepare the child if feasible, such as explaining how timeout works. For unexpected misbehavior, try to discipline when you are calm. Behavior orientation always disapprove of the behavior, not the child. You want to say things like, that was the wrong thing to do, or I am unhappy when I see behavior like that. Privacy. We don't want to embarrass the child, so you want to discipline them in private, especially with older kids. And termination. Once they have been disciplined, they have a clean slate. You don't want to be bringing it up at a later time. So timeout is a very common type of disciplinary technique that we use for our younger children. The way it works is you want to select an area for timeout that is safe, convenient, and unstimulating, but where the child can be monitored, such as a bathroom, hallway, or laundry room. We don't want a frightening area, so like a dark place, a cellar, or a closet. That would not be appropriate. You want to determine what behaviors warrant a timeout. Make sure children understand the rules and how they are expected to behave. Explain to children the process of timeout. When they misbehave, they will be given one warning. If they do not obey, they will be sent to the place designated for the timeout. They are to sit there for a specified period of time. If they cry or refuse or display any kind of disruptive behavior, timeout begins once that behavior has stopped. When they are quiet for the duration of the time, then they can leave the room. A rule of thumb for timeout is 1 minute per year of age. You do want to use a timer, and that way they know when their time is up. Implementing a timeout in a public space by selecting a suitable area or explain to the child that the timeout will be spent immediately on returning home. You can even mark their hand with a felt tip pen as a reminder to let them know when we get home because you misbehaved, you're going to go in timeout. Often that fixes the behavior. Positive and negative reinforcement is the basis of behavior modification therapy. Behavior that is rewarded will be repeated. Behavior that is not rewarded will be extinguished. Consistently ignoring behavior will eventually extinguish or minimize the act. Corporal punishment. This is based on aversion therapy. So inflicting pain through spanking causes a dramatic short-term decrease in the behavior, but there are many problems with spanking, and quite frankly, we strongly discourage this. It teaches children that violence is acceptable. Many times the spanking is a result of parental rage and may physically harm the child. Children become accustomed to spanking and require more severe corporal punishment each time. Kids that are spanked are less likely to learn what they're supposed to do because it focuses on what they should not. When the parent is not around, they might not behave in the way that they want them to because they have not learned to behave well for their own sake. Discipline techniques should help the child control their own behavior. Techniques could include withholding privileges, imposing penalties, penance activities, contracting. Allow the child to participate in the process of determining appropriate disciplinary measures. Sadly, there's quite a few people that experience divorce, and it's important to understand how that will impact children. So in infancy, they are affected by divorce because there can be an issue with the attachment process, and you might see an increase in irritability, problems with eating, sleeping, and excreting. Children that are experiencing divorce of their parents between 2 and 3 years of age might be frightened and confused. They might blame themselves. They might have a fear of abandonment, increased irritability. They may have more tantrums. You might see regressive behavior, thumb sucking. If they were potty trained, maybe they are now wetting the bed. You might see separation anxiety. 3 to 5 years of age, again, you're going to see that fear of abandonment. They might blame themselves. They might have a decrease in self-esteem. You might see some aggressiveness with others. 5 to 6, you might see some depression and immature behavior, loss of appetite and sleep disorders. They might be able to verbalize some feelings and understand some divorce-related changes. They might feel abandoned by the departed parent. 6 to 8 years of age, you might see panic reactions, feelings of deprivation, like the loss of a parent, attention, money. They might feel like their future is not secure. They can also have feelings of sadness, depression, fear, and insecurity. 9 to 12, here they have a more realistic understanding of divorce. They can have intense anger directed at one or both parents. They might have divided loyalties. They are able to express their feelings of anger, shame, of parental behavior, and they might even feel the need for revenge. They might engage in lying, stealing, temper tantrums, and even have a dictatorial attitude. Age 12 to 18, here they're able to disengage themselves from the parental conflict. They will feel a profound sense of loss of their family, childhood. They can have feelings of anxiety. They might worry about themselves, their parents, their siblings. They can express anger, sadness, shame, and embarrassment. They might withdraw from their family and friends. They can develop or have a sense of a disturbed concept of sexuality, and they might engage in acting out behaviors. So let's talk a little bit about some special parenting situations. So one is single parenting. This is where one parent is raising the child, and as I stated before, 35% of children under 18 live in a single parent household, most of which are women. Problems include the children are more likely to stay poor, commit crimes, be a source of disciplinary problems in schools. The mother is often overtaxed as the nurturer and disciplinarian, as well as the breadwinner. Money, time, and energy are major concerns for the single parent. Single fathers, when they have custody of their children, they also have some of the same problems as single mothers. They can feel overburdened by responsibility, depressed, concerns about their ability to cope with the emotional needs of their children, especially their daughters. Some fathers lack homemaking skills. They might find it difficult at first to coordinate household tasks, school visits, and other activities associated with managing a household alone. Parenting in reconstituted families. So this is that blended family. The entry of a step parent requires adjustment for all family members. Parenting tips for living in the situation include: let the relationship develop slowly and naturally. Don't criticize or try to replace the other parent. Decide on standards of discipline and behavior and stick to them. Don't pretend everything is fine when it isn't. Open communication is paramount. Cooperative parenting or joint custody relationships allow for each set of parents to be alone and establish their relationship with their children. Parenting in the dual earner family. Here, problems include overload as a common source of stress. Time demands, scheduling are major problems. Often social activities are curtailed. Childcare is very critical to the working mother's well-being. Parents have to make sure they investigate childcare services before use. Parenting the adoptive child. Most problems faced by adoptive parents are not much different than natural parents. The sooner the child enters an adoptive home, the better the parent for parental bonding. Most authorities believe a child should be informed of their adoption so that they do not really remember a time that they didn't know that they were adopted. Children might use the fact of their adoption to manipulate their parents. They need the same love, discipline, and limit setting as other children. Some want to know their biological parents in order to define who they are, develop their own identity. In some states, birth certificates are made legally available to adopted children when they come of legal age. Parents should be honest with questioning adolescents and tell them of this possibility. The parents themselves are unable to obtain the birth certificate. It is the child's responsibility if they desire it. Family structure. So this can be considered a little stereotypical, but it's just something kind of fun and interesting. So here they say the firstborn children are often concerned with achievement. They tend to be more dominant. They plan better and experience fewer frustrations. Middle children, here they have more demand for household help. They tend to be praised a little bit less often, but they do learn to compromise and be more adaptive. The last born, I always call it the babies of the family. They tend to be more outgoing, less tense, more affectionate, good-natured, and have fewer demands placed on them for chores. Sociocultural and environmental influences are many. Examples of these would be the school and learning environment, peer culture, local community influences, social roles, mass media, race, ethnicity, co-cultural influences, poverty, parent education, land of origin and immigration status, religion and spirituality, cultural humility, and healthcare providers' contribution. School, about 5 or 6 years of age, kids can spend anywhere from 6 to 8 hours in school each day. Physical skill and social interactions are learned, and also they can learn about health and nutrition. Stress. There are quite a few stressful events that can occur in a child's life. Things like moving, new schools, divorce, abuse. Signs and symptoms of stress in kids can be things like regressive behavior, poor sleep, hyperactivity, GI signs and symptoms like vomiting, diarrhea, or constipation, or nausea as well, withdrawal from normal events, and unexplained crying. Community. If a social area has plenty of like nice after school programs and safe parks, that's lovely. But if they are in an economically depressed area where they have few services and a high homicide rate, obviously that is not a great environment for children. Communities can be sites of opportunity for growth for children and families. They can also be a place where there's poverty and disenfranchisement, and that's obviously not helpful. These can be minimized through connections with high quality early childhood education. They can also be minimized with job training for adolescents and parents, and developing safe and effective schools. Communities can also contribute to toxic stress if violence and poverty are pervasive and resources are absent. Low socioeconomic status sadly can lead to poor nutrition, lack of immunizations, and an increase in injuries and an increase in teen pregnancy rate, homelessness, and poor health care, especially if they don't have insurance. Poverty. Physical poverty refers to a lack of money or material resources. This includes poor nutrition, insufficient clothing, poor sanitation, and deteriorating households. Invisible poverty refers to social and cultural deprivation, such as limited employment opportunities, lack of or inferior healthcare services, and an absence of public services. Because of the evolving demographics in the United States, it's critical pediatric nurses care for children and families in an open, culturally humble manner. The family's religious orientation dictates a code of behavior and influences the family's attitude towards education, male and female role identity, and the various aspects of their life. It might also influence the school that the child attends or the community in which the family embeds itself. Guidelines for integrating spiritual care into the pediatric nursing practice. You want to respect the child and the family's religious beliefs and practices. Consider the child's development when talking about spiritual concerns. Contact the institution's chaplaincy department for patients and families who have symptoms of spiritual distress or ask for specific religious rituals. Become knowledgeable about the religious worldviews of cultural groups found in the patients you care for. Encourage visitation with family members, members of the patient's spiritual community, and spiritual leaders. Allow children and families to teach you about the specifics of their religious beliefs. Develop awareness of your own spiritual perspective. Listen for understanding rather than agreement or disagreement. Media. Violence on TV and video games is associated with aggressive behavior. There's an increase in cyberbullying. Increased amounts of time watching TV is associated with increase in weight. Alcohol and tobacco and vaping products are often marketed to young people. Body image dissatisfaction can be due to unrealistic portrayals in the media. Sexual content in the media can contribute to beliefs and attitudes about sex, sexual behavior, and initiation of intercourse. The American Academy of Pediatrics recommends no more than 2 hours of age-appropriate TV per day for children 2 years old and over. There should be no screen time for children under the age of 2. Studies show that children who watch more than 1 hour of TV a day have higher obesity rates. Race. This is a term that groups together people by their outward physical appearance. Race is a socially constructed term with roots in anthropology, distinguishing a variety in humans by physical traits. Culture is food, values, patterns of social interaction, attitudes towards touching, appropriate behavior based on gender. Culture characterizes a particular group with its values, beliefs, norms, patterns, and practices that are learned, shared, and transmitted from one generation to another. Ethnicity is the affiliation of a set of persons who share a unique cultural, social, and linguistic heritage. Ethnicity is a classification aimed at grouping individuals who consider themselves or are considered by others to share common characteristics that differentiate them from the other collectivities in a society and from which they develop their distinctive cultural behavior. Health beliefs and practices. These beliefs can be related to the causes of illnesses and the maintenance of health. These are integral parts of a family's cultural heritage. The concept of balance or equilibrium is widespread throughout the world. One of the most common imbalances is one between hot and cold. This can help nurses to understand why patients do or don't want to eat certain foods or fluids. Some folk remedies are compatible with medical regimes and are useful to reinforce the treatment plan. Nurses must respect practices that do not harm patients and educate people when the practices can cause harm. Please note, nutrition is the single most important influence on growth for all ages. Chapter 3, Concepts of Growth and Development. Growth is an increase in physical size. This is a quantitative change. We can easily measure height, weight, head circumference. Development, an increase in capability or function. This is qualitative changes, mastery of skills. Typically, it goes from easy to more complex. These are not easily measurable. So usually you're going to see a gradual change from lower activities to more advanced stages of complexity. Differentiation. This is a process in development where unspecialized cells are systematically modified to achieve specific physical forms, physiologic function, and chemical properties, such as a stem cell differentiating to a B and T cell. Maturation. This is a process of developing, including physical, emotional, and intellectual abilities that let one function at a higher level and adapt to the environment. An increase in competence, adaptability, and aging. Some say a person is matured when they are able to put aside or delay their own needs. Sensitive periods. There are limited times during the process of growth when the organism interacts with a particular environment in a specific manner. Periods termed critical, sensitive, vulnerable, and optimal are the times in the lifetime of an organism when it is more susceptible to positive or negative influences. Developmental milestones. These are a physical or cognitive skill that a person must accomplish during a set age period to continue developing. So let's talk a little bit about some principles of growth and development. Human development follows a set direction and sequence. From simple to complex, First, the baby will coo, and then eventually, as they progress, they will start to develop words. It's from general to specific. First, they will have palmar grasps, and then more fine finger movements. It's head to tail, cephalocaudal. First, they're going to have controlled movements of the head, neck, body, and then the limbs. It's near to far or proximal distal. First, the arms are coordinated before the hands get more specifically coordinated. And then predictability. Although development occurs in a set order, there's a very wide range of normal. Typically, kids are walk anywhere from 9 to 15 months of age. So that's a very wide range of normal. Your textbook will say typically we expect to see this by 13 months. Kids usually do follow a consistent pattern. That is, if they develop early, then they have a pattern of developing early, versus if they are developing on the later end of normal, then they tend to follow that developmental pattern as well. When children learn new developmental skills, the new skills will predominate over older skills. Let's take a look at general trends in height and weight gain during childhood. Birth to 6 months of age, we expect to see a weight gain of 5 to 7 ounces a week. Birth weight doubles by the first 4 to 7 months. Height, usually they will gain 1 inch a month. 6 to 12 months, here you're going to see 3 to 5 ounces weekly, and birth weight typically triples by the end of the first year. Monthly gain is usually about 1/2 inch a month, and usually birth length increases by about 50% by the end of the first year. So if they were born 20 inches, by the first year, they'll be 30 inches. So that's how you know it's 50%. Toddlers' birth weight quadruples by age 2.5. Height at age 2 is about half of the eventual adult height. Preschoolers, usually they gain 2 to 3 kilograms, or that's 4.5 to 6.5 pounds. Birth length doubles by 4 years of age, and they usually have a yearly gain of 2 to 3 inches. School age children, they have a weight gain of, again, of 2 to 3 kilos, which is 4.5 to 6.5 pounds. And they have a yearly gain after age 7 of about 2 inches. Birth length triples usually by 13 years of age. Females 10 to 14 will have their, that's a typical age for their pubertal growth spurt. Usually they'll have a weight gain of 15.5 to 55 pounds. They can have a height gain of 2 to 10 inches, and they achieve about 95% of their mature height by the onset of menarche. Males, their weight gain from 11 to 16 doing their growth spurt is usually 15.5 to 66 pounds. Their height is about 4 to 12 inches. And they usually have about 95% of their height by 15 years of age. Yearly height and weight gains for each age group represented average estimates from a variety of sources. Let's talk a little bit about children's temperaments. This is one's behavioral style or approach to people and situations. There are 3 general patterns, but know that 35% of children have some but not all characteristics in one category. So the easy child. This child has a positive mood, easily adapts to new stimuli and situations. They are accepting of rules. They work well with others. And this is about 40% of children. The difficult child. This is a child that generally has a negative mood. They have intense reactions to the environment. They slowly adapt to new people and new situations. They tend to be highly active, irritable, and irregular in their habits. This is about 10% of children. Slow to warm up child. This is a child who's initially withdrawn. They slowly will interact with the environment. They are quiet. They have mild reactions and slowly adapt to new situations. This is about 15% of children. Let's talk a little bit about theorists of development. The first one we're going to talk about is good old Freud. He is the psychosexual therapist, actually, and theorist. And he believed that early childhood experiences form the unconscious motivation for actions later in life. The personality has three parts: the id, which is the seeks pleasure. The ego is the realistic part. This protects self from anxiety with ego defense mechanisms. And the superego, which is the moral system. And this is the one that has the values and conscience. Stages. The oral stage, so this is birth to about a year. They get pleasure and comfort from the mouth. So sucking, eating, biting, chewing, vocalizing. What can we do as a nurse? Well, here, if a child is NPO, they can have a pacifier, or even giving it to them during or after a procedure. Anal stage, this is 1 to 3 years of age. Gratification by controlling bodily excretions. The climate surrounding toilet training can have lasting effects on a child's personality. As a nurse, what can we do? Follow the toilet training rituals at home and at the hospital. Know the words used for stool and urine. So number 1 might be pee, number 2 might be poop. Don't start to toilet train in the hospital. You might see regression regarding toilet training if the child is hospitalized. They might be wetting the bed in the hospital when they didn't do that at home. That's okay, that's not uncommon. And typically when they go back home, they are potty trained again. Children who had rigid, severe toilet training most likely show meticulous and hypercritical behaviors later on in life. The phallic stage, this is 3 to 6. The child initially identifies with a parent of the opposite sex, but by the end of this stage, they identify with a parent of the same sex. Children recognize differences between the sexes and become very curious about dissimilarities. Nursing application, here we try to assign an RN, a nurse they are going to be comfortable with. Latency, this is 6 to 12 years of age. Here they're concerned with privacy and understanding of the body. Physical and psychic energy are channeled into acquisition of knowledge and vigorous play. What can we do as a nurse? Make sure we knock on the doors, provide gowns and proper draping, explain treatments and procedures. Genital stage is 12 to 18. This is a focus on genital function and developing friendships and preparing for marriage. Nursing application here, making sure that they have information on sexuality, birth control, make sure they have privacy during their health care, GYN exams, making sure males know about their testicular exams and things of that nature. Next, we will talk about Erikson's theory of psychosocial development. Erikson identified 8 periods of time in one's life. Each developmental crisis must be met to successfully move on to the next. If it's not met, then it negatively affects future social relationships. Because this is pediatrics, I will only be identifying the first 5 periods that Erikson has talked about. So the first stage is trust versus mistrust. Again, birth to a year. Trust is fostered by having all of their needs met. Mistrust develops if the basic needs are inconsistently or not adequately met. So you want to, again, offer comfort after a procedure, meet hygiene and other physical and social needs. Autonomy versus shame and doubt. This is about 1 to 3 years of age. And here the development of autonomy is centered on children's increasing their ability to control their bodies, themselves, and their environment. Independence is shown by saying no, controlling excrement, and directing motor activity. If criticized or unsuccessful, they may develop a sense of shame and doubt. So what can we do as a nurse? Allow them to feed themselves, encourage them to dress themselves and participate in hygiene activities. If you need to restrain this child, Please do so quickly and with an explanation. Initiative versus guilt. This is 3 to 6 years of age. Here you'll see vigorous, intrusive behaviors, strong imagination. They demonstrate initiative by being able to formulate and carry out a plan of action. They like to start new activities, new ideas, and explore the world. Here they are developing a conscience. When they're made to feel that their activities or imaginings are bad, that produces a sense of guilt. When efforts to engage in physical and imaginative play are stifled by others, children begin to feel that their self-initiated efforts are a source of embarrassment. So what do we do here? You want to encourage them to draw as a means of expressing their feelings and acknowledge them and let them play with medical equipment to decrease their anxiety. Industry versus inferiority. So this is stage 4, 6 to 12 years of age. Here they gain a sense of self-worth from involvement in activities. If they are successful, they develop confidence. They enjoy learning about new things. If they're compared to others, they might develop feelings of inadequacy. And inferiority may actually develop if too much is expected. So what can we do as a nurse? We want to encourage them to continue to do their schoolwork and to engage in their favorite pastimes that they do at home, if it's possible for them to do that in the hospital. The last stage that we will talk about for Erickson, because it's in the pediatric age range, is identity versus role confusion. This is 12 to 18. Here, this is when that teenager is searching for identity. They want independence from their parents, and they have an increased reliance on their peers. They have rapid and marked physical changes, preoccupation with physical appearance. Peer group is very important. If they're successful, they develop confidence and self-identity. If they are unable to make meaningful definition of their self, they can develop role confusion. So what do we do as a nurse? We want to do our history and physicals with the teen alone, or at least partially alone, so they can speak to us in an open, frank manner. Let them meet other teens with similar health problems. Provides a separate area from small children for teens only, like a recreation room. Piaget's cognitive learning theory. So this is a cognitive developmental theory, and basically it says that cognitive development is influenced by age and maturational ability. The child incorporates new experiences via assimilation, which is absorbing the information, and changes to deal with experiences by accommodation. This is adjustment or adaptation. Stage 1. This is sensory motor, and this is from birth to 2 years of age. And this is where they learn about the world with their senses and motor activities. This has 6 substages. The first one is the use of reflexes, birth to 1 month of age. They receive stimulation by using reflexes, so the first learning can occur. The second substage is primary circular reactions, 1 to 4 months of age. Pleasure is gained from reflexes that causes repetition. They grasp a rattle, it makes noise, baby likes how it sounds, they look at it, they grasp it again. Third substage, secondary circular reactions. This is 4 to 8 months. Here they're starting to connect that cause and effect. They will be happy when a bottle is prepared, or if the child is nursing, if they see the mom unbuttoning their blouse to feed them, they're going to be happy because they're going to start to connect that cause and effect. Here they also will try to uncover a partially hidden object. Substage 4 is coordination of secondary schemes. This is between 8 and 12 months. This is where they develop that object permanence by 10 months of age. It is no longer out of sight, out of mind. They will perform intentional behavior to get objects. They create sounds. They're associating symbols with events. So if somebody waves goodbye, they understand that the person is leaving. Substage 5 is tertiary circular reactions. This is 12 to 18 months. This is where they will explore actions to learn results. They might get an object and look at it at different angles. They'll bang on it. They'll place it in its mouth. They try to explore its uses. They use achievement experimentation to do whatever they couldn't do in the past. Know that they don't transfer new information from one situation to a different one. They will examine an object over and over again as if they've never seen it before. So they can see a telephone in one room and then they can see a telephone in a different room and it'll be as if they've never seen it before, and they will examine it very thoroughly. You'll also see this when a child is maybe playing with a light switch in the kitchen, and if you take them to another room and there's a light switch, you'll see them playing with it again as if they've never seen it before. The last subset, which is 6, is mental combinations. And this is 18 to 24 months of age. This language really helps child to think about events or objects before or after they occur. It really helps them to understand the world around them. There's an increasing development of object permanence in the sense that they will look for things that are hidden. They'll participate in domestic mimicry, meaning that they will imitate household chores. They will imitate your actions, gestures, and words. Stage 2 is pre-operational. This is from 2 to 7 years of age. Children use language and have a growing understanding of the past, present, and future. This has 2 substages. One is preconceptual. This is your 2 to 4-year-olds. They can only see things from their own perspective, meaning that they are egocentric. Logic is not developed. And then next they have an intuitive substage, which uses transductive reasoning, meaning that they can draw conclusions from one fact to another that are not related. So an example of this would be that they got sick because they were bad, or they got appendicitis because their dog's tail hit them in the stomach. They can have magical thinking, which means they think things happen because of thoughts or wishes. So they can be thinking, I wish my brother was dead, and unfortunately, just as a coincidence, the brother does die, and they will think that they caused that. The nurse and everybody else would need to tell that child that they are not responsible for their illness or someone else's illness. 3, this is concrete operational, also known as perceptual thinking. This is usually from 7 to 11. Here they're able to reason cause and effect. They can develop the ability to problem solve. They understand rules and can base judgments on reason. They need to be able to manipulate objects and see objects. They do master concepts of conservation, meaning that environmental properties don't change just because something looks different. Like one tall glass can be 8 ounces and one short glass can also be 8 ounces. They may have the same amount of water, but they look different. Classification. This is where they group similar things together, and in this age group, they like to collect things like coins, stamps, shells, Beanie Babies. Collections are a big deal to these kids. Reversibility is also being developed in this time frame. And so here they're able to think through an action, and then they can think of the benefits and the consequences. So if they're playing chess, they can say, should I make this move or should I make a different move, because that will cause a different result. Also during the concrete operational time, this is typically when they're learning to read. What can we do as nurses here? Let them see and touch the equipment that's to be used, give clear instructions for treatment and procedures. Formal operational, this is your conceptual thinking or your abstract thinking. This is your 11 to 15-year-olds. And this is the ability to think, as I said, abstractly and consider different alternatives and outcome. They also will determine logical consistency or inconsistencies. So if their parents are cheating on their taxes, but they say you need to be honest, a teen's gonna call you on that. What can we do as nurses here is give verbal and written information and full explanations of treatments and procedures. Kohlberg. So this is the moral theorist, and this has 3 general levels, and they are divided further into their own sub-levels or sub-stages. So the first level is pre-conventional morality. Here at the pre-conventional level, this is most 9-year-olds and younger, some over 9. They don't really have a personal moral code. Instead, it's shaped by adults and the consequences of breaking rules. So stage 1 is obedience and punishment orientation. The child is good in order to avoid being punished. If a person is punished, must have done something wrong. Stage 2 is individualism and exchange. At this stage, the child recognizes that there is not just one right view that is handed down by authorities, that different individuals can have different viewpoints. Level 2, which is conventional morality. Here, authority is internalized but not questioned. Reasoning is based on the norms of the group to which the person belongs. This is typically at the adolescent and some adults. So the 2 stages here is good interpersonal relationships, and this is where the child is good in order to be seen as being a good person by others, and therefore the answers relate to the approval of others. And then the second stage of that, or stage 4, the whole theory, is maintaining the social order. And this is where the person becomes aware of the wider rules of society. So judgments concerning obeying the rules in order to uphold the law and to avoid guilt. The third level, so a lot of people don't quite get here. Basically, they say only about 10 to 15% are capable of the kind of abstract thinking necessary for stage 5 or 6, which is the post-conventional morality stage. That is to say that most people take their moral views from those around them, and only a minority think through ethical principles for themselves. So stage 5, this is social contract and individual rights. Basically, this is they become aware that while rules and laws exist for the good of the greatest number, there are times when they will work against the interest of a particular individual. So the issues are not always clear-cut. For example, the protection of life is more important than breaking the law against stealing. Stage 6 is the universal principle. People at this stage have developed their own set of moral guidelines, which may or may not fit the law. The principle applies to everyone. So things like human rights, justice, and equality, the person will be prepared to act to defend these principles, even if it means going against the rest of society in the process and having to pay the consequences of disapproval and or imprisonment. Kohlberg doubted few people reach this stage. A little bit about the development of self-concept. So basically, self-concept is how an individual describes him or herself, including all notions, beliefs, and convictions that constitute an individual's self-knowledge and that influence that individual's relationship with others. To develop a positive self-concept, children need recognition for their achievements and the approval of others. Body image, this is the subjective concepts and attitudes that individuals have towards their own bodies. Self-esteem, this is the value that an individual places on oneself and refers to an overall evaluation of oneself. The role of play in development. Children can learn through play what adults are unable to teach them. They can learn about their world and how they deal with and operate within their environment. Play should follow a directional trend from simple to complex. Through the universal medium of play, children learn what no one can teach them. Play really is the work of children. So let's take a look at the content of play. The content of play follows the directional trend of the simple to complex, although social relationships cannot be ignored when we're looking at play. So one type or content of play is the social affective play. This begins with play wherein infants take pleasure in relationships with people. Sense pleasure play is a non-social stimulating experience. It originates from without. Objects in the environment attract the child's attention, stimulating the senses and give pleasure. Skill play. After infants have developed the ability to grasp and manipulate an object persistently, They demonstrate and exercise the newly acquired abilities through skill play by repeating an action over and over again. Unoccupied behavior. In unoccupied behavior, children are not playful, but focusing their attention momentarily on anything that strikes their interest. Dramatic or pretend play, also called symbolic play, is the predominant play in preschool. They act out events of daily life. Games. Children in all cultures engage in games either alone or with other people. Please note that preschoolers hate to lose and they will actually cheat to win. School age and adolescents do enjoy competitive games. There are quite a few different types of play according to social character. So here, one is onlooker play. And this is where they watch activities with interest, but there's no movement to participate. An example of this would be watching an older sibling bounce a ball. This is a very common example for onlooker play. Infancy, what kind of play do we see them participate in? Typically, it is solitary play. They play alone. They will play with different toys than others around them. So they like rattles, cloth books, music, colorful mobiles, and squeaky toys. The toddler, they typically participate in parallel play. They will play next to each other with little or minimal social interaction. Using pool toys, big wheels. They might use similar toys others are using, but they are not influenced by other people playing around them. Preschoolers, here they do associative play. These children are now interacting with each other and engaging in similar activities. They'll participate in groups, they'll play house, build Legos, but there's really no organization with the play, and they kind of do their own thing, although they're doing their own thing together. School age, here they participate in cooperative play. So here you would see things like the child learns to put the needs of the group ahead of their own. No, in the US, winning is often very significantly emphasized. And really, we want children to participate in games, to enjoy playing the game. Of course, everybody wants to win, but we want to let them know that it's important to enjoy playing the game. Also, children learn to understand the rules and their roles in the game. Functions of play. So play enhances sensory motor development, intellectual development, socialization, creativity, self-awareness, therapeutic value, moral standards. Play is therapeutic at any age. Although there is no scientific evidence that shows that any particular toy is necessary for optimal learning, toys do offer an opportunity to bring children and parents together. The type of choice chosen by or provided for children can support and enhance the child's development. Toys that are small replicas of culture and its tools help children assimilate into their culture. Toys that require pushing, pulling, rolling, and manipulating teach them about physical properties of an item and help them build muscles and coordination. Rules and basic element of organization are learned through board games. Let's talk a little bit about developmental assessment. There is a screening test called Ages and Stages Developmental Screening Test. This includes 19 age-specific surveys that ask parents about developmental skills common in daily life for children. This assesses development in 4 categories. The age range is from 1 month to 66 months, and it looks at physical, intellectual, language, and social emotional. Parents fill out this form, and then if there's a problem, further screening is done. A developmental assessment determines whether the child has mastered certain expected accomplishments during a developmental stage. If not, subsequent tasks may be delayed. There is something called a Denver 2, or it's Denver Developmental Screening Test. Just kind of FYI, the American Academy of Neurology and Child Neurology, they don't really recommend it because they say that it lacks, or it is insensitive and lacks specificity. Just kind of FYI also, when we are doing a developmental assessment, if a child is born prematurely, we must adjust the age. And basically you adjust the age by looking at the number of weeks a child was born premature, and then you subtract from the chronological age to determine the infant's developmental age. So you're going to do this until the child is about 2 years of age. An example would be if a child is born 4 weeks early and their chronological age now is 16 weeks. So if they're 4 weeks early, we're going to minus 4 from 16, which is 12 weeks. So you would, even though they're 16 weeks old, you're going to assess them at the 12-week milestone. So this concludes Part A for Week 1 objectives. Please remember to do Part B. Thank you, and see you when I see you.